We all want to see healthcare professional training get better, right? It's something many of us think about.
Absolutely.
And if you've ever been involved in, designing or running these programs, you know it's tough. It's a real puzzle.
It really is,
Mm.
especially keeping up with what society actually needs.
Exactly. It feels like we're constantly trying to figure out the best way forward, how to refine things.
It's definitely a shared challenge across health professions education. We're all aiming for impactful learning, but figuring out how to truly measure that impact and then improve it. That's the tricky part.
That is the core of it.
Yeah.
And that's what we're diving into today. We want to explore how two key approaches, quality improvement, QI and program evaluation, can actually work together.
Right, how they can be combined.
Yeah, combined powerfully to really boost these educational programs. It's about finding that sweet spot where we don't just assess things, but we have the tools to actively make them better, more effective.
Precisely. It's a shift, isn't it? Moving from just judging merit to driving active improvement. We're drawing heavily today from an article by Allison Brown and Lawrence Grierson.
Two sides of the same coin, right?
That's the one. Quality improvement and program evaluation in health professions education. They make a really compelling case for this synergy.
Okay, let's dig in.
Yeah.
So the authors start by reminding us, quite rightly, that medical schools aren't islands. They're deeply connected to society.
Mm-hmm.
Deeply.
And they have a huge influence, don't they, on patient care, obviously,
Mm.
but also on who even gets to become a doctor and ultimately healthcare access.
It's a massive responsibility when you frame it like that.
Yeah.
And because of this, many medical schools have these social accountability mission statements.
Right. They're public commitments.
Exactly. Pledges to address specific societal health needs. And this often leads to programs designed to, say, widen access to medical training or focus on underserved areas.
The goal being to produce doctors who will actually practice effectively in those communities.
That's the intention. But, and this is a big but, uh-oh.
Research suggests these programs, however well-intentioned, don't always hit the mark.
Really? So there's a gap between the mission statement and the actual results.
Often, yes, a gap between aspiration and reality. And Brown and Grierson point a finger at a potential reason.
Which is?
They suggest the accreditation culture might play a role. Sometimes it seems to prioritize just having these socially relevant programs.
It's like ticking a box.
Kinda, yeah. Rather than rigorously proving their actual outcomes and impact.
That rings true. It's easier to say you have a program on rural health than to show your grads are actually working effectively in rural settings long term.
Exactly. And while some schools do track outcomes, the authors argue it's often limited. Short-term stuff.
Like what? Student satisfaction, exam scores.
Things like that, yeah. Which are important, but they don't necessarily tell you about the longer-term effects on the learners, their future patients, or the communities they serve.
So we're measuring the immediate reaction maybe, but not the lasting change.
Pretty much. And the authors say evaluations need to do more. They need built-in mechanisms for making improvements as you go, or at least a clear path for action afterwards.
Not just a final report card that sits on a shelf.
That's the key problem they're highlighting, that lack of action, that disconnect between evaluation and actual improvement. And that's where QI comes into the picture.
Okay, let's define QI then. Quality improvement. What does it actually mean in this education context?
So at its core, QI uses systematic methods to make a system perform better. It's about looking at the structure, the processes, the day-to-day stuff, and the outcomes, and finding ways to enhance them, usually at a local level. It's not just a vague philosophy of let's get better. It involves specific frameworks and tools.
Got it. And the article mentions its roots are actually in manufacturing. Way back.
Yeah, early 1900s. It's got a long history. And it's different from, say, quality assurance or quality control.
Ah.
Well, QA and QC are all about maintaining a standard, checking against benchmarks. QI is more about an internal drive for deliberate, iterative improvements.
Yeah.
Pushing to reach new levels of performance.
And it's already used a lot in healthcare itself, isn't it? For patient safety and things like that.
Absolutely. Reducing errors, improving safety, enhancing outcomes, it's widespread. And health professions education has recognized this. QI principles are being integrated into competency frameworks.
So the idea is that graduating professionals should be able to contribute to improving the systems they work in.
That's the goal. They should be change agents, in a way.
So what do these QI frameworks typically look like? What are the common threads?
Well, they usually focus on improving a specific local system. That's key. They rely heavily on continuous data collection to guide the changes.
Data-driven.
Very much so. There's typically some kind of leadership or executive function setting goals and indicators. And critically, they all use a set of tools and methods in iterative cycles.
Iterative cycles.
Yeah, testing changes, learning from the results, adapting, testing again. Small steps, usually.
The article mentions one specific model quite a bit, the model for improvement.
Yes, that's a really common one, especially in healthcare settings. It's often taught to medical students and residents.
So how does it work?
It's cyclical. It starts with 3 questions. What are we trying to accomplish? How will we know that a change is an improvement? And what changes can we make that will result in improvement? This helps define a clear aim and a family of measures.
Family of measures.
Yeah, you look at outcome measures, the results you want. Process measures are the steps in the system performing as planned. And balancing measures are your changes causing any unintended negative consequences elsewhere.
Okay, makes sense. Aim, measures. Then what?
Then come the PDSA cycles. Plan, Do, Study, Act.
PDSA. Heard of that.
Right. You plan a small test to change. You do it, implement it on a small scale. You study the results, analyze the data, see what happened, and then you act based on what you learned, adopt the change, adapt it, or abandon it.
So it's like rapid cycle experimentation. Learn fast, adjust fast.
Exactly. And crucial to all QI work, including the model for improvement, is context.
Ah, context again.
Always.
Yeah.
In medical education, context is everything. It's the patients, the clinical settings, the teaching environment, the wider societal factors. It's incredibly complex and dynamic.
And medical education itself influences that context, but is also shaped by it, right?
Precisely. Think about things like putting students in rural placements or specific specialty rotations. Those are deliberate manipulations of context to achieve certain educational goals.
Right.
And this is where QI really shines. If you're trying to implement something that worked elsewhere, maybe a new curriculum model or teaching technique, QI gives you a framework to adapt it effectively to your specific local context.
Because just copy and pasting often doesn't work.
Rarely does perfectly. The authors mention failures when things like problem-based learning or even online modules were just replicated without considering the local nuances and adapting them. QI provides that adaptation mechanism.
So it helps ensure that good ideas actually land effectively in a specific, unique setting.
You got it. That tailoring process can be the difference between success and failure.
Okay, so that's QI. Now let's contrast it with program evaluation. How does program evaluation differ fundamentally?
Well, their origins are different, for starters. QI from engineering and manufacturing, like we said. Program evaluation really grew out of education back in the 1940s.
Okay.
Initially, evaluation was often about checking if a program met its stated objectives. Pretty straightforward. But it's evolved a lot.
How so?
It's moved towards more theory-based approaches, trying to understand how and why programs work or don't work, looking at mechanisms, unintended consequences, the whole picture.
So digging deeper than just pass-fail.
Exactly. The paper summarizes some key differences nicely. Let's look at the main objective.
Okay.
For program evaluation, it's generally about understanding how well a program is working within its context. For QI, the objective is more focused. Reach a new, improved level of performance locally.
Different goals. What about methods?
Different toolkits, too. Evaluation uses models like CIPP context, input, process, product, or logic models. Kirkpatrick's levels, lots of frameworks. QI uses things like the model for improvement, Lean, Six Sigma.
Right, and the typical output. What do you get at the end?
An evaluation usually gives you a comprehensive understanding what worked, what didn't, why, what else happened. A deep analysis.
And QI?
QI aims for sustained improvement in the system, a measurable change for the better.
So evaluation gives understanding, QI drives tangible change, and the purpose of the knowledge generated.
Also differs. Evaluation findings are often used to demonstrate merit or worth to stakeholders, funders, leaders, accreditation bodies, evidence for judgment.
Whereas QI knowledge
Is primarily used internally to ensure the improvement is real, sustainable, and embedded locally. Knowledge for action.
Okay, that clarifies things. One point the authors really stress is how evaluation sometimes isolates metrics from context, while QI sees context as integral. That feels important.
It's a huge point. If you pull metrics out and judge them without deeply considering the why and how tied to the local context, your conclusions might be, well, incomplete.
And maybe not very useful for actually making things better.
Exactly. It can lead to evaluations delivering a verdict without offering a clear roadmap for enhancement based on those contextual factors.
The article mentions newer evaluation types like developmental evaluation. What's the deal there?
Yeah, Patton's developmental evaluation focuses on rapid feedback and adaptation, especially for programs in complex, changing environments. It sounds quite aligned with QI in some ways.
But it hasn't caught on widely in medical education, apparently.
The authors speculate why. Maybe it's perceived as less structured, or maybe it doesn't always provide the clear-cut summative judgments that institutions sometimes feel they need for accountability.
Plus, maybe a bit of risk aversion in med ed. Experimentation can feel edgy?
That could certainly be part of it, too. Which leads back to a critical issue they raise: evaluation utilization.
Meaning actually using the findings.
Precisely. The depressing reality is that evaluation findings often just sit there. They don't get translated into actual program improvements.
That seems like such a waste of effort.
It really is. They talk about instrumental utilization when findings directly inform concrete actions. They argue that should be a key measure of an evaluation's success. Did it lead to change?
If not, what was the point, really?
Right, so this sets the stage perfectly for integrating the two approaches.
Okay, let's get into that synergy. How can QI actually enhance program evaluation? The authors argue it provides that missing mechanism for improvement.
Exactly. They see them as complementary, not competing. And they suggest a few ways to integrate them.
Like using QI before the main evaluation.
Yes, use QI in the initial design and rollout of something new, like a pilot phase or proof of concept.
Why is that helpful?
Well, launching a new educational intervention in a complex system like a medical school is tricky. Things can go wrong. You might even see performance dip initially after a big change.
Right, the implementation dip. You want to minimize that.
Definitely. So using QI early, maybe PDSA cycles with a small group, lets you test and refine the intervention. Tailor it to your local context before you go big.
Sort of working out the kinks first.
Exactly. You address feasibility issues, fidelity problems, logistical challenges on a small scale. Then, once it's working reasonably well in your setting,
then you do the broader program evaluation.
then you can evaluate it more formally to get that comprehensive understanding of its effectiveness and why it's succeeding, or maybe why it's still falling short in some areas.
That sounds really practical. It's like beta testing for education. The article had that example of the interprofessional program.
Yes, the experiential learning for pre-clerkship students. They use the model for improvement right at the start.
What did they test?
Things like different clinical settings, how long students should shadow, the best timing, scheduling issues, how to prepare the learners beforehand, all tested using PDSA cycles.
And that helped them optimize it.
It did. It refined the program components and, importantly, helped them successfully spread the initiative later on. They built a solid, context-adapted foundation first.
Okay, so that's QI before evaluation. What about using QI after an evaluation?
This is maybe more common for existing programs. You do an evaluation, it identifies strengths and weaknesses.
Right.
Then you use QI methods specifically to tackle those weaknesses. The evaluation points to what needs fixing, and QI provides the structured approach to develop, test, and implement the how.
So the evaluation diagnoses the problem, QI provides the treatment plan.
That's a good analogy, yeah. It's especially useful if a program didn't use QI initially and now needs changes based on evaluation data. QI tools can help you refine bits, maybe eliminate things that aren't working, or carefully test adding new components.
The article mentioned using it to expand a community service learning program.
Yeah, based on evaluation findings suggesting areas for growth or improvement, they could use QI to iteratively test each step of the expansion. New partners, new activities, making sure it works well in each new context.
Okay, so before, after. What about doing them at the same time? Concurrently.
This is about embedding QI, specifically those PDSA cycles, throughout the evaluation process itself.
How would that work?
As you're collecting evaluation data and seeing how things are going, you're not waiting until the end. You're actively looking for opportunities for small improvements right now.
Making adjustments on the fly based on real-time data.
Essentially, yes.
Yeah.
Testing small changes based on emerging evaluation insights. It's a very dynamic, responsive approach.
And the authors connect this to accreditation standards, the LCME.
They do. The LCME actually requires medical schools to have ongoing planning and continuous quality improvement processes.
Right.
That lead to measurable outcomes, which are then fed back into program improvement. So this concurrent model fits really well with that expectation of continuous data-driven enhancement.
This whole integration idea feels really powerful, especially thinking back to those social accountability missions, making sure those programs are actually effective.
Absolutely. And the authors note this link between QI and evaluation hasn't gotten a ton of attention in the medical education literature.
Really? Seems like a natural fit.
You'd think so, but often QI gets mistaken for just basic quality assurance or box checking for accreditation, like we discussed.
But it's more than that.
Much more. They mention a couple other models, like from Bolin and Woolard and Clitero et al., that really capture this spirit of active feedback loops, refining programs based on local needs, constantly striving for better outcomes. That's the essence of QI.
So, weaving QI into evaluation shifts the focus firmly onto improvement. It makes the evaluation actively drive positive change.
That's the core argument. It leads to more sustainable improvements and helps ensure programs are truly responsive to societal needs and actually produce evidence of impact.
It connects the mission to measurable, improved outcomes.
Precisely. It helps institutions move beyond just stating their intentions to actually demonstrating their effectiveness in training health professionals who can make a difference.
Okay, so wrapping this up, the big takeaway seems clear. Program evaluation on its own is vital. We need it.
No question.
But it's often not enough to drive real change. By strategically integrating quality improvement methods, whether that's before, during, or after the evaluation,
You create a much more powerful system.
yeah, you get a practical pathway to move beyond just assessing programs to actively, meaningfully enhancing them. It tackles that initial challenge of translating good intentions into tangible results.
It really does. It makes the whole endeavor more effective, more responsive, and ultimately more accountable.
So here's something for you, the listener, to think about. In your own work, whether it's education, professional development, or something else, how deliberately are you applying improvement principles?
hmm
Are your evaluation efforts just measuring things? Or do they have a built-in, clear, iterative pathway for actually making things better based on what you learn? Could integrating some QI thinking help you not just understand your outcomes, but actively drive them forward?
It's a powerful question to ask. Are we set up just to judge, or are we set up to improve?
Definitely something worth reflecting on.